Bismillahirrahmanirrahim. My name is Dr. Talha Munir. I am consultant physician in Medical Unit 4, DHU Hospital, Islamabad and FMU. Today I am going to teach you a very important topic, that is rheumatoid arthritis. Rheumatoid arthritis is a chronic multisystemic disease of unknown cause. The characteristic features of established rheumatoid arthritis is persistent inflammatory synovitis, usually involving peripheral joints in a symmetrical distribution. The potential of the synovial inflammation to cause cartilage damage and bone erosions and subsequent changes in joint integrity is the hallmark of the disease. The important point to consider here is that जब जो synovial membrane होती है joints के अंदर, जब वो inflamed हो जाती है तो ये इन्फिल्ट्रेट कर जाती है उसके अंदर, कार्टिलेज को भी डिस्ट्रॉय करती है, बोन को भी डिस्ट्रॉय करती है और अल्टीमेटली जो जॉइंट का एक स्ट्रक्चर है उसको भी इन एडवांस डिजीज़ में डिस्ट्रॉय करती है. तो साइनोवियम जो है दैट इज़ सॉर्ट ऑफ एक्टिंग एज डिज़ास्टर फॉर द जॉइंट. How to diagnose rheumatoid arthritis? There is a set clinical criteria defined by American College of Rheumatology and European League Against Rheumatism. This criteria is based on a scoring system with 4 parameters with different scores, and a combined score of 6 or greater than 6 is required to make a definite diagnosis of rheumatoid arthritis. Four parameters include number of joints affected, serology, which includes rheumatoid factor and anti-CCP antibodies, anti-citrullinated protein antibodies, duration of symptoms and acute phase reactants, which include CRP and ESR. So if one large joint is involved, we have 0 score. 2 to 10 large joints, we have 1 score. 1 to 3 small joints, we have 2 scores. 4 to 10 small joints, we have 3, and greater than 10 joints with at least 1 small joint, we score it as 5. You can see in the scoring system that small joints have more score as compared to large joints. So rheumatoid arthritis mostly affects small joints as compared to large joints, although they are affected as well. Regarding serology, if we have negative rheumatoid factor and negative ACPA, then we give 0 points. But if any of them is positive but in a low titer, then we give 2 points, and high titer positive rheumatoid factor or anti-CCP, we give 3 points. The duration of symptoms is less than 6 weeks, we give 0 point. If symptoms duration is greater than 6 weeks, then we give 1 point. And last, regarding acute phase reactants, if CRP and ESR is normal, we give 0 point, and if CRP or ESR is raised, we give 1 point. When we add these points of the 4 parameters to the score of 6, makes a diagnosis of rheumatoid arthritis. Similarly, when a diagnosis of rheumatoid arthritis has been established, and a patient is being treated for RA, to monitor the disease, there is another score which is called Disease Activity Score 28, which is universally accepted score. In this scoring system, again we have certain parameters to count. We have to count number of swollen joints, count tender joints, measure ESR, and note patient global health assessment, which is scored between 1 and 100. This is a subjective assessment in which patients is given a performer, and patients tells his symptoms and scores his disease between 1 to 100. This data is entered into a calculator which is easily available on web by the name of DS28 calculator. There is a complex equation which we don't need to remember or see that equation. The interpretation is important. If we have a score of 5.1, it means that disease is highly active and the treatment must be escalated or intensified. If the disease is 2.6 to 5.1, it means that disease is fairly controlled, but again treatment needs to be reviewed. If the score is less than 2.6, then it means that disease is in remission and it's in adequate control. Regarding epidemiology and genetics, prevalence of RA is 0.8% in general population, and it is a female predominant disease with ratio of 3:1 or male to female ratio 1:3. Fourth and fifth decades of life is a predominant age in which RA is diagnosed in almost 80% of the cases. There is also genetic predisposition with the increased incidence of rheumatoid arthritis in first degree relatives. Although exact cause of rheumatoid arthritis is not known. Regarding clinical features, there is symmetrical deforming polyarthropathy affecting the synovial membrane of peripheral joints. So the word symmetrical is very important. At the start disease could be asymmetrical. पहले एक हाथ से स्टार्ट हो सकती है, दूसरा हाथ नॉर्मल होगा. Ultimately, because it is a systemic disease, so it involves both sides of the body, both hands, both feet, etc. Approximately 2/3 of patients, it begins insidiously with fatigue, anorexia, generalized weakness, and vague musculoskeletal symptoms until the appearance of synovitis becomes apparent. This is very important point in rheumatology, that initially we can only have fatigue, anorexia. Patient आएगा जस्ट कहेगा जी हर वक्त थका रहता हूँ, खाने को दिल नहीं करता. एंड आई हैव वेग मस्कुलोस्केलेटल सिम्टम्स कि मुझे दर्दें होती हैं, कड़लें पड़ती हैं और मुझे कमज़ोरी होती है. सुबह उठता हूँ तो दिल नहीं करता बेड से उठने को और जिस्म जो है वो स्टिफ सा फील होता है. लेकिन क्लासिकल फाइंडिंग्स जो हैं साइनोवाइटिस की, जिसमें इन्फ्लेम जॉइंट्स हैं या एनी अदर डिफॉर्मिटी, वो नहीं मिलती. तो इट डजेंट मीन दैट पेशेंट इज़ नॉट अ केस ऑफ रूमेटॉइड आर्थराइटिस. हो सकता है इस वक्त जो क्लिनिकल क्राइटेरिया है वो पूरा ना हो रहा हो, बट विद पैसेज ऑफ टाइम इन नेक्स्ट 2 to 3 months जो सिम्टम्स हैं ज़्यादा क्लियर हों तो फिर क्राइटेरिया हो सकता है फुलफिल. तो अगर आपका क्लिनिकल सस्पिशन स्ट्रॉन्ग है तो वी नीड टू रिव्यू आवर डायग्नोसिस with passage of time. RA most often causes symmetrical arthritis with characteristic involvement of certain specific joints. Rheumatoid arthritis में certain joints हैं जिसकी ये disease ज़्यादा affect करती है, which includes proximal interphalangeal joints and metacarpophalangeal joints. One very important point to note here is that the distal interphalangeal joints, जो आपकी finger का last joint है, that is categorically spared in rheumatoid arthritis. If distal interphalangeal joint is involved, then it means that it's not RA. अगर distal interphalangeal joints involved हैं तो that occurs in osteoarthritis and in psoriatic arthritis. Psoriatic arthritis जो है इसका strong differential diagnosis है rheumatoid arthritis का, because it is also an inflammatory arthritis which occurs in psoriasis. Rheumatoid arthritis can also involve C1 and C2 vertebra, which is very dangerous if it erodes the vertebra, which can compress spinal cord and result in paralysis of the patient, quadriplasis. The early morning stiffness, pain, swelling are the classical signs of rheumatoid arthritis. Synovitis of the wrist joints may lead to limitation of motion, deformity, and median nerve entrapment. When there is inflamed synovium, it affects joints as well as the periarticular muscles and periarticular soft tissues, in which median nerve can be entrapped, which is called carpal tunnel syndrome. Another thing is Baker's cyst, which develops in the knee joint. It can also involve the axial skeleton. As already discussed, atlantoaxial subluxation C1-2 vertebra can present in as pain in occiput region, but in rare occasions may lead to compression of spinal cord. Now, regarding examination of a patient with rheumatoid arthritis, in early stage we can only find vogy, warm joints in typical distribution of symmetrical polyarthropathy. In hands there are some classical signs, which is ulnar deviation, swan neck and boutonniere deformity, and any tendon ruptures due to infiltration of the inflammatory cells from the joint and synovium. In wrist we can have radial deviation, synovial proliferation may compress median nerve. Again, this point is emphasized. In feet, again like hands, in feet we can have subluxation at metatarsophalangeal joints, skin ulceration and painful ambulation. Large joints in large joints are affected as whole surface in a symmetrical fashion. For example, median and lateral compartment of knees. This is a photograph of a swan with swan neck deformity of the hand, in which there is flexion of the distal interpharyngeal joint and extension of the metacarpopharyngeal joint. Again, you can see this deformity. The other deformity which is commonly found is boutonniere deformity, in which there is opposite phenomena occurs with extension of the distal interpharyngeal joint and flexion of the flexion of the metacarpopharyngeal joint. This is the photograph of boutonniere deformity. फिश माउथ डिफॉर्मिटी, इसको फिश माउथ डिफॉर्मिटी भी कहा जाता है. Now these are the classical hands of rheumatoid arthritis, which is poorly controlled. You can see all sort of deformities with destroyed joints, ulnar deviation, radial deviation, swan neck deformity. Again, this picture shows destroyed joints with ulnar deviation, and you can also see rheumatoid nodules in the metatarsal regions. Characteristic changes: rheumatoid arthritis, late stage boutonniere deformity, ulnar deviation, swan neck deformity. So radial deviation at the wrist with ulnar deviation of the digits, again with palmar subluxation of the proximal phalanges. At very late stage, when all the joints are destroyed, it is also called arthritis mutilans, in which the whole joint loses its integrity and you cannot exactly designate any deformity to the joint. So we call it arthritis mutilans, which means the joint is almost completely destroyed, and we have to replace that joint if it's possible. Typical changes may also develop in the feet. Eversion of the foot can occur. Plantar subluxation of the metatarsal heads can occur, which can lead to ulceration in the palmar surface of the foot as well. Now this is another diagram showing changes in the feet. Regarding extra-articular manifestations, as rheumatoid arthritis is a chronic inflammatory disease, systemic inflammatory disease, so there are findings in the outside joint musculoskeletal system as well. These manifestations are mostly evident in people with high titers of autoantibodies to the Fc quotient, which is called rheumatoid factor, which we discussed in the diagnostic criteria of rheumatoid arthritis. Also anti-CCP antibodies, which is antibodies against its-related proteins. These are also an important antibodies to look for in rheumatoid arthritis. Common findings: fatigue, weight loss, low-grade fever. Subcutaneous nodules are very important. Almost exclusively occur in seropositive patients. Seropositive हम उन patients को कहते हैं जिनमें rheumatoid factor positive हो. And it is thought to be triggered by small vessel vasculitis. Carpal and tarsal tunnel syndromes, capsulitis of the shoulders with secondary frozen shoulder is a common finding. Increased mortality and morbidity from cardiovascular disease. This point is very important. In rheumatoid arthritis, mortality from cerebrovascular disease is very much increased as compared to normal population. Uncommon findings include polyarthritis nodosa like vasculitis, pyoderma gangrenosum, pericardial effusions, pulmonary effusions, diffuse interstitial fibrosis of lungs, scleritis, which can result also in scleromalia with thinned out sclera, mononeuritis multiplex with due to involvement of or entrapment of multiple nerves, and C1-2 myelopathy. Regarding rheumatoid nodule, which occurs in 20 to 30% of the patients, these are periarticular structures which are commonly found on extensor surfaces in areas subjected to mechanical pressure. Rheumatoid nodules can also occur in pleura and meninges, and that can result in fits and secondary epilepsy as well. This is a photograph showing rheumatoid nodules on the knee joint. Clinical weakness and atrophy of skeletal muscles is another important thing. When the joints are affected, the supporting muscles or the muscles which are attached through affected joints, they also get atrophied as they are disused due to involvement of painful joints. So, or also inflammation can infiltrate into muscles, which these factors result in atrophy of the relevant muscles of the joints as well. Rheumatoid vasculitis is another important phenomenon which is polyneuropathy and mononeuritis multiplex is a manifestation. Cutaneous ulceration and dermal necrosis is also found in rheumatoid arthritis, but it is less common finding. Digital gangrene and visceral infarction can also occur in some cases. Pleuropulmonary manifestations. In lungs, pleura can be affected with also interstitial fibrosis of lungs. Pulmonary nodules can also be found. Pneumonitis and arthritis and pulmonary hypertension is also a finding in the rheumatoid arthritis in late stages. When they appear in individuals with pneumoconiosis, a diffuse nodal fibrotic process called Kaplan syndrome may develop. So if a already patient of pneumoconiosis, rheumatoid arthritis occurs, then this syndrome is called Kaplan syndrome. Chronic constrictive pericarditis and congestive heart failure are the other complications of rheumatoid arthritis with inflamed pericardium. Neurological manifestations results from atlantoaxial or mid-cervical spine subluxations, nerve entrapment, polyneuropathy due to vasculitis, as already discussed in detail in previous slides. Eye involvement, episcleritis and scleritis. Sclera can be involved with inflammatory cell infiltration with thinning of sclera and can result in tear and rupture as well. Fell's syndrome is another syndrome that is very common, which is very important in rheumatoid arthritis. It occurs in chronic rheumatoid arthritis with splenomegaly and neutropenia, the classical findings. Osteoporosis can occur due to disease plus due to therapeutically we have to give steroids in rheumatoid arthritis, so it can be iatrogenic or it can be due to increased inflammation in the body due to rheumatoid arthritis. Hematological manifestations, there is increased incidence of non-Hodgkin's lymphoma in patients of rheumatoid arthritis, so we need to be very vigilant if patients develop any lymphadenopathy or any cell line disturbances in peripheral blood film, so we need to be on close watch for lymphoma. Regarding investigations in blood works, anemia of chronic disease is common in rheumatoid arthritis with raised ESR and CRP as already discussed. Rheumatoid factor क्या चीज़ होती है? Rheumatoid factor is basically autoantibodies for the Fc portion of the IgG antibody. So it is an autoantibody against our own IgG antibody. It is found in more than 2/3 of the adults with the disease. Presence of rheumatoid factor can be of prognostic significance because patients with high titers tend to have more severe and progressive disease with extra-articular manifestations due to formation of immune complexes. Important thing is that rheumatoid factor can be found in 5% of healthy persons without any obvious evident disease. Conditions associated with presence of rheumatoid factor: systemic lupus erythematosus, Sjogren, chronic liver disease, sarcoidosis, tuberculosis, hepatitis B, malaria. Anti-CCP antibody, it has a similar sensitivity and a better specificity for RA than does rheumatoid factor. It can be found in 1.5% of normal. Laboratory evaluation as first baseline investigation with CBC, renal functions, liver function tests, serum chemistries, synovial fluid analysis if there is effusion in the joint, rheumatoid factor, CRP, anti-CCP antibodies, and imaging of the joints as well. Acute phase reactance, as already discussed, needs to be measured. One of the most responsive acute phase reactants is C-reactive protein, which correlates with the disease activity and radiological progression. So to monitor our treatment, we can have CRP monitoring, which can guide us in our treatment. Similarly, ESR is also important, but CRP is more specific and important to monitor disease in rheumatoid arthritis. Synovial fluid examination is also important with an exudative fluid, reduce viscosity, increase protein content, and slightly decrease or normal glucose concentration. The white cell varies between 5 and 50,000 per liter. Regarding radiology, X-ray of hands and feet, loss of joint space, soft tissue swelling, erosions, particularly fifth metacarpal and metatarsal joints of and ulnar, styloid and scaphoid trapezium. These are the bones which are commonly eroded in rheumatoid arthritis. Periarticular osteoporosis, joint destruction, these are all the features which can be found in imaging of radiology in rheumatoid arthritis. Now this image is showing a soft tissue swelling and periarticular area with erosion in the proximal interphalangeal joints in a patient with rheumatoid arthritis. The blackish area which you can see in a whitish bone are the erosion of the joint, of the bone. This is another image of hands, X-ray of hands showing deviation of the fingers and periarticular swelling with erosion of the bones. This you can see ulnar deviation of the hand with subluxation of the joints as well as erosions in the middle phalanx. Just juxtaarticular osteopenia and reduced joint space is evident in this picture. And on the right side you can see X-ray of cervical spine with atlantoaxial subluxation. This is a picture of a knee joint with reduced joint space. Risk factors for increased morbidity and mortality in RA. Social factors. If RA occurs in low socioeconomic status and disease has a relatively poor prognosis due to multiple factors, if patient disease is not properly managed, patient has psychosocial stress or low IQ score, low lack of formal education. Regarding physical factors, extra-articular manifestations, elevated CRP, high titers of rheumatoid factor, erosions on X-rays, duration of disease, these are all bad prognostic factors in rheumatoid arthritis. Differential diagnosis, viral syndromes with hepatitis B or C, EBV, psoriatic arthritis, reactive arthritis, SLE, sarcoidosis, these are some important differential diagnosis to look for when rheumatoid arthritis diagnosis is made. Now, regarding goal of therapy, we have to control disease activity, alleviate pain, maintain function for essential daily activities, maximize quality of life, and slow progression or rate of joint damage. These are the goals of therapy. Non-pharmacological measures include rest, splinting, exercise, orthotic and assistive devices, education of the patient and family. Pharmacological agents include use of NSAIDs and simple analgesics, oral steroids, disease-modifying anti-rheumatic drugs, biologics which includes monoclonal antibodies, immunosuppressive and cytotoxic drugs, and substituting omega-3 fatty acids in some studies helps also in rheumatoid arthritis. NSAIDs provide symptomatic relief, but it has limited role or minimal role in altering any disease process. It only provides symptomatic relief with no role in disease progression. DMRDs are very important. They appear to have the capacity to alter the course of RA. So we need to be vigilant and start disease modifying anti-rheumatic drugs early so that joint destruction can be prevented and later patient morbidity and can be prevented as well. It retards the development of bone erosions. These include methotrexate, sulfasalazine, hydroxychloroquine, cold salts, D-benzylamine. A combination of DMRDs appear to be more effective than single agents in controlling the signs and symptoms of RA. Glucocorticoids provide symptomatic relief. They serve as a bridge when our immunosuppressive or DMRDs take time to act. So meanwhile, we give steroids for a few weeks to suppress inflammation. The typical is 7.5 milligram per day dose of prednisolone. Avoid using without a DMRD. Only steroids should not be used. They should only be used as a bridge therapy. Biologics includes TNF neutralizing agents, IL-1 neutralizing agents, anakinra, B-cell depleters, rituximab is very important, and abatacept which interferes with T cell activation. Immunosuppressives include leflunomide, cyclosporin, azathioprine, cyclophosphamide. The last, if the joint is severely affected and it's hindering in daily activities of the patients, so we can have surgical intervention in these patients. Orthoplastics and total joint replacements are options. The most successful procedures are carried out on hip joints, knee joints, and shoulders.